Good evening, everyone. My name is Melinda Singh Mahal. I'm the GP Cancer Education Coordinator at the Cancer Council. Welcome to our seminar tonight, Less Common Cancers, Pancreatic Cancer. I'd like to acknowledge the traditional owners of the land we meet on today, the Noongar Whadjuk people. I would also like to pay respect to the elders, past, present and emerging, and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present. I have a couple of housekeeping points before we begin. We do encourage you to ask questions as you go along, and you can submit your questions in the Q&A chat function at the bottom of your screens. We'll address as many of these as time allows at the end of both the presentations. We will also send out an online evaluation following the presentations tomorrow. We do encourage you to participate in the evaluation so we can get some feedback on our webinars. And in the evaluation that you will be sent tomorrow, you will see a mention of a website for the Cancer Australia Pancreatic Cancer Roadmap. Cancer Australia and the Department of Health are developing a national pancreatic cancer roadmap. It supports improved outcomes experienced by people diagnosed with pancreatic cancer. The roadmap will identify priority areas for action over the next 5 years. It will consider all aspects of the cancer pathway, including research, prevention, early detection, diagnosis, treatment, support and palliative care. So currently Cancer Australia are consulting with stakeholders, including health professionals. So you as general practice are encouraged to have your say. You can follow the link and provide your feedback there. So first up tonight, we will hear from Dr. Chris Loma. Chris is a medical oncologist who works at Fiona Stanley Hospital. So I'll just hand it over to Chris. Thank you.
So, g'day everyone. My name's Chris. I'm an oncologist at Fiona Stanley. And I'll just give you a bit of a talk about the medical oncologist's approach to pancreatic cancer. So we're kind of involved in 3 ways. We're involved with giving adjuvant or neoadjuvant chemotherapy. So giving chemotherapy most commonly after, but also often before surgery. And giving chemotherapy in locally advanced disease. So this is when the cancer is not resectable but hasn't spread outside of the pancreas. So giving chemotherapy in that situation, and then also giving chemotherapy in metastatic disease. Also talk a little bit about side effects of chemotherapy and also some of the symptoms that our patients have when they progress. So this was a slide I found on one of the GP educational talk when I was preparing for this presentation. So this is just a slide from the new staging system that came out a couple of years ago, just showing that pancreatic cancer is unfortunately not a great cancer, and the prognosis is still very poor. Even with a stage 1 early stage patient who's getting a very good treatment with surgery and chemotherapy and occasionally radiotherapy, you can see there the median overall survival is still much less than 5 years, and then coming down lower and lower to roughly 10-12 months with stage 4 disease. So still an area of great need, and unfortunately patients still have a poor prognosis with these cancers. There's been a lot of changes in oncological treatments in the last few years with developments of targeted therapy and immunotherapy and lots of other therapies. But unfortunately, none of that has really impacted the pancreatic cancer space, and we're still using kind of old-fashioned chemo from many years ago. So there's basically 2 chemotherapy regimes that we have for pancreatic cancer. There's a regime called FOLFIRINOX, and that's mostly given in the adjuvant, neoadjuvant, and locally advanced setting. And then we have another regime called gemcitabine nab-paclitaxel, which is given mostly in the metastatic setting. Now, these 2 regimes have never been compared head-to-head, so it's a little bit unclear which is best or worse in each of these scenarios. But according to PBS rules and generally the evidence would support using FOLFIRINOX for non-metastatic patients and using gemcitabine and nab-paclitaxel in a metastatic setting. Side effects are different, and we'll talk about that in a moment, but it is a relatively simple cancer to treat from a medical oncology point of view because there are only these two treatment regimens. So just moving on now to our first topic, which was adjuvant chemotherapy. So this slide is just meant to demonstrate that how the treatment of pancreatic cancer has changed over the years. If you go back to 2007, the adjuvant regime we were using was a drug called gemcitabine, and at that time, the median overall survival was 23 months. The most recent trial, a French trial, Prodigy 24, which came out only a couple of years ago, has shown a pretty big increase in a year compared to that earlier Conco trial. And you can see that advantage was with the same chemotherapy, so 1 year better with the same chemotherapy. So obviously, it's not the chemotherapy making the difference in the patients living longer. It's it's the surgical techniques getting better. It's getting better at selecting our patients, knowing when and who to give chemotherapy to. So there's still a great amount to be gained from a non-chemotherapy treatment for patients, and that's what this slide is meant to demonstrate. And we are getting better at that over time as well. Similarly, our chemotherapy is getting better, and we now have this regime called FOLFIRINOX, which is a pretty heavy-duty regime, but gives patients a much better overall survival than other regimes. Unfortunately, because it is a little bit heavy-duty, not all patients can tolerate it. So sometimes in that case, we might consider going to a less heavy-duty regime with good but maybe not as good outcomes. And so in those cases, we would decide between a gemcitabine or a different regime with gemcitabine, capecitabine. So just about this regime of FOLFIRINOX, it's like I said, it's pretty heavy duty. It's got 3 chemo drugs all mixed in at once. The standard treatment is 6 months. So patients would get treatment every fortnight with chemotherapy for 12 doses. They go home with a 48-hour infusion as well. So they need central line access either with a PICC line or an infuser port. They would come in and get their chemo, say on a Monday, come back on a Wednesday, get the chemo disconnected, and then come back 2 weeks later and start again. Because of that 2-week cycle with this regime, we expect most of the side effects to be around about days 7 to 11 with this regime. Obviously, they could get side effects at any time, but that's probably the high risk time for getting things like febrile neutropenia. In the study, that Prodigy 24 trial, 20% of the patients were over 70 years. So even though it's relatively heavy duty, still, a lot of patients who are, I guess, elderly or geriatric patients, still appropriate to treat them with this regime. But over 1/3 or about 1/3, couldn't get through the full 12 cycles. So, it is a little bit heavy, but most patients don't find it too bad. And we would certainly discuss it with most patients, even if they're old and a little bit frail, although we might downgrade them to one of those less heavy forms of chemo. There is a little bit of a question mark about whether if a patient has an R1 resection, whether they should get some adjuvant radiotherapy. So in a situation where patients had microscopic disease at the margin at surgery, whether there's a role for postoperative radiation, data is slightly controversial as to whether that offers a benefit. So those patients will be considered on a case-by-case basis. But I think most of them, I think Mandy might agree, would end up going for post-op radiation. So we do have a trial because it is a heavy regime, and as I mentioned, 1/3 of patients don't complete the regime. We've got a trial going on at Fiona Stanley Hospital called the Dynamic Pancreas Trial, where we're looking to see if we can de-escalate chemotherapy from 6 months to 3 months. So we're sending off the DNA, circulating tumour DNA of the patient. So we take a blood test, send it off to the study headquarters in Melbourne. They check if there's any cancer DNA in the blood. And if there is, the patient gets the standard 6 months of treatment. And if it isn't, they get 3 months of chemotherapy. So we're trying to see if we can, reduce toxicity from patients by using other biomarkers to guide our treatment. And we've got a number of patients on this trial, and many of them have said that they'd stop chemo, but as they know it's only going for 3 months because their ctDNA was negative, they're happy to push on for 3 months. So just a bit of a plug for our hospital. So just moving on now to locally advanced disease. So there's been a bit of a treatment shift over the last few decades in locally advanced pancreatic cancer. So this is pancreatic cancer where it hasn't spread outside of the pancreas, but because of the location of the tumour and the other structures involved near or with the tumour, it's unfortunately not operable. So in the 80s and 90s, we used to give radiation and chemo. Then it switched to give the chemo first and the radiation. Now we give chemotherapy and then we and ah and have a discussion with the patient about whether they should or shouldn't have radiotherapy. So there was a study called the LAPO7 study, and they looked at doing radiation or nothing. And on that trial, it showed that giving radiotherapy delayed the time to cancer progression, but the patients didn't actually live longer. So the main benefit of radiotherapy in the locally advanced setting is to give them a break off chemo and to give them a longer break off chemo. So routinely now for the locally advanced cancer patients, we give them 3 to 6 months of chemo, scan them. If it hasn't progressed or if it's not metastatic at that point, we'll have a chat with the radiation oncologist about whether there's a role for radiotherapy. They might offer some radiotherapy. We might give them some gentle tablet chemotherapy with that. And then after that, we'll just sit back and watch and observe and wait and scan them every couple of months. And then if and when it becomes metastatic, then we'll talk to them about chemotherapy for metastatic disease. And this is just the data there, the Kaplan-Meier curves from that LAPO7 study, which you can see shows a progression-free survival advantage for radiotherapy, but no overall survival advantage. Again, the same regime that we talked about for adjuvant and near-adjuvant patients, where we give FOLFIRINOX, or for your less fit patient, gemcitabine, for 3 to 6 months, repeat the scan, and then think about radiation at that point. I think it's probably fair to say that most patients won't have progressed in that time. The thing about the difference between chemotherapy and radiotherapy is the thing that would get the patient in the end is the metastatic disease. So, giving them chemotherapy as a trial to see what the biology of their tumour is like, to see if it's a really aggressive one that's going to spread, and therefore radiation wouldn't have been worthwhile anyway, is a good thing. So giving them chemotherapy first has been shown in those previous studies to be the way to go. There is a role for radiation also in the locally advanced setting for patients who are getting symptoms from their cancer. So things like pain or symptoms from obstruction, say a gastric outlet obstruction or even a biliary obstruction, and might be a role for radiation in that setting as well. It's often hard to give those patients who are very symptomatic chemotherapy because of their symptoms. So there might be a role earlier on for radiation for symptom control in those patients as well. So moving on now to metastatic disease. So unfortunately, metastatic pancreatic cancer has a very poor prognosis even with treatment. And unfortunately, we don't have any new fancy treatments yet. There's a lot of work going into molecular mutations with pancreatic cancer. So hopefully we have some new treatments for our patients in the future, but at the moment it's just old-fashioned chemo. The location of the tumour is extremely important to the prognosis and the symptoms as well, whereas a head of pancreas cancer has a lot worse prognosis and a lot more difficult to treat than a tail of pancreas cancer. Patients, unfortunately, often have quite significant symptoms, especially pain. Abdominal pain is very common. Weight loss, very common. jaundice, especially if it's in the head and obstructing the biliary system, gastric outlet obstruction, ascites causing symptoms like shortness of breath and abdominal pain, and fatigue is very common as well. So I guess most of those would be regarded as typical cancer symptoms. This is just showing again the kind of evolution over time of the treatment for metastatic pancreatic cancer, where gemcitabine was used in the old days, still an active regime, but not as active as the newer regimes, FOLFIRINOX and gemcitabine nab-paclitaxel, the two regimes I mentioned at the front. Again, never been compared head to head, so unclear which one is best. But I think it's probably fair to say that gemcitabine nab-paclitaxel is regarded as a slightly less toxic regime, and therefore would for most people be a first choice regime in the metastatic setting. The difference might be if a patient has a large tumour causing symptoms, and you really need to shrink it down, and in that case you might give FOLFIRINOX. You can see there the response rate for FOLFIRINOX was a little bit higher than gemcitabine nab-paclitaxel, which means that the tumour shrinks more with, or more likely to shrink with FOLFIRINOX than it is with the other regime. And that is why FOLFIRINOX is generally preferred in a neoadjuvant setting, because it shrinks down the tumour and allows patients to get the operation. The overall survival was similar between the two regimes, and slightly higher 1 year survival rate, or I guess a significantly higher 1 year survival rate for gemcitabine nab-paclitaxel. It is important to note that the FOLFIRINOX trial did exclude patients who were older, so over 75 patients, patients who had an ECOG score of 2. They were excluded for that trial. So it's more reserved for, I guess, your slightly younger, slightly fitter patient that you would think about maybe giving that regime to. But that would be the exception. I think most patients, even if they're younger and fitter, would be started on the gemcitabine nab-paclitaxel regime. So just a bit about that regime. That's a regime where they get chemotherapy 3 out of every 4 weeks. It's a 2-drug regime. They come in, they get both drugs by infusion. It takes a few hours. Then they come back next week, do it again, next week, do it again, have a week off, and then start another cycle. And that would be generally continued until disease progression or toxicity. I'd say most patients on average would, if they're doing well, we'd be, kind of thinking they've done quite well if they've got 8 or 9 months out of this regime. I wouldn't have thought we'd have too many that would get more than that out of that regime before their disease progresses. So just another plug for Fiona Stanley Hospital, where we've got a trial in the metastatic setting for pancreatic cancer, a trial which is comparing the gemcitabine nab-paclitaxel regime versus a regime that's very, very similar to FOLFIRINOX, but they've just slightly tweaked one of the drugs. So that'll give us a lot of information about how to best treat first-line treatment for metastatic pancreatic cancer. So just quickly moving through some chemotherapy side effects. This was from the PREDIGE-24 trial, and it just shows that although the FOLFIRINOX regime has a relatively high level of grade 3 to 4 neutropenia, so neutrophils less than 1, the rate of febrile neutropenia was, I guess, pretty low at 3%. We are allowed to give a white blood cell factor or neutrophil support with a GCSF for these patients. I don't commonly do it unless they're a particularly high risk or they get side effects or they get neutropenia during their treatment. I don't start it normally as the first line, but that option is available. But other common side effects with diarrhea, so having a grade 3 to 4, which is considered a significant side effect at about, just under 20%. And also peripheral neuropathy. You probably see a lot of your patients on chemotherapy get peripheral neuropathy. Unfortunately, many of our drugs can cause that, and pretty high rate there with peripheral neuropathy and paresthesia as well. And that can often be a dose-limiting toxicity, and that's the one toxicity that is a permanent toxicity as well. So patients often left with a residual neuropathy after they finish their treatment. Compared to the gemcitabine nab-paclitaxel side effects, you can see there was 4% patients had a side effect leading to death. Rate of neutropenia pretty high, 40%. Febrile neutropenia pretty low, 3%. Fatigue and peripheral neuropathy pretty similar to FOLFIRINOX. Pretty common side effects as well, unfortunately, with this regime. So it's hard to switch from one regime to the other because peripheral neuropathy is often the dose-limiting toxicity for both of these regimes. So just finally now moving through to symptoms. So pain, especially abdominal pain from the primary mass, is very common, and we would just generally use opioids or Pentadol for that. They have very severe pain, and we might consider a celiac access block, and that can be quite effective. Not always effective, probably pretty effective in about a third, kind of okay effective in about a third, and not that effective in about a third. Then you can have problems from the location of the tumour causing obstruction, leading to jaundice, leading to infection, meaning it's difficult to treat, requiring stent, in and out of hospital, on and off antibiotics, can't give them their chemo. That's a very common presentation, fortunately. Gastric outlet obstruction, again, can be a problem, requiring intervention with a nasojet feeding or stenting or potentially radiotherapy. Weight loss and fatigue are common. Occasionally we'll start steroids for that, but it's kind of a bit of a bridge to nowhere. You never know when to end the steroids, so it's certainly not something we do with relish, but we will occasionally throw some steroids at the patient to see if we can turn that around. Ascites can be very common, so we'll treat that with paracentesis, either with a temporary drain or a permanent drain. And then having DVTs and pulmonary embolism are very, very common as well. There is some data to show that putting patients on prophylactic anticoagulation might decrease the rate of clots, but it's never been shown to have any more advantage than that. So it's not part of my routine practice, but you might occasionally see that as well. So that's it for my talk. So in summary, unfortunately, the prognosis for pancreatic cancer is not great, even with good resection and adjuvant chemotherapy, but over time it is getting better slowly. We've got 2 chemotherapy regimes, which in the moderate to heavy kind of toxicity regimes.
Thank you, Chris. Next, our speaker is Dr. Mandy Vavaria Mundra. She is a consultant at Fiona Stanley Hospital. She is a general pancreatic and hepatobiliary surgeon. I'll hand it over to you now. Thank you.
Hi, my name is Mandy, and I'm one of the consultant general RPGI surgeons over at Fiona Stanley Hospital. And just giving you a brief overview on, I suppose, diagnosing pancreatic cancer and a little bit about how the journey works in terms of, I think many of you probably have patients who get asked to turn up for investigations, etc., before they actually get seen in a clinic. And I'll just explain some of that as we go along. I've kept the talk to pancreatic adenocarcinoma and excluded any sort of discussion around cysts, apart from a small mention here and there, and also steered away from talking about neuroendocrine tumors. So pancreatic adenocarcinoma is a relatively, I suppose, less common cancer, and that only represents about 2.7% of new cancers in Australia a year, but about 6.9% of deaths from cancer, and is about the 8th most commonly diagnosed cancer in 2020, but is likely to become the 3rd most common cause of death in 2020. I think it was previously about 4th. Despite some changes over the years, there's been little improvement over the last 2 decades, possibly with a 5-year survival that's improved very little, from about 3.6% 2 decades ago for 5 years, and up to about 11% now. As you know, most cases occur between the ages of 60 and 80, slightly greater propensity in men than women, 50% higher. There is a familial basis for pancreatic cancer, probably about 10%, but most of these won't actually have a genetic basis. These will just be people with a family history of pancreatic cancer, but no actual known genetic mutation. although it can also be a feature of some of the genetic syndromes, including Lynch, BRCA1, Peutz-Jeghers. Those are patients that are actually likely to be screened, although there's no good screening programs per se for them. Other risk factors include risk factors that are common to most cancers, so things like smoking and obesity, but also diabetes and chronic pancreatitis. Within chronic pancreatitis, there are problems related to diagnosing patients with chronic pancreatitis with malignancy as well, because some of the features may overlap, and indeed some of the inflammatory changes may look mass-like, which would be long-standing and purely related to inflammation, but they can also be underlying lesions associated, which can be missed or at least delayed in diagnosis, even with surveillance. In terms of presentation, the majority of people with early cancers will be asymptomatic, so they'll have no symptoms. The vast majority of patients referred to us are not, do not have a surgical option and will have metastatic disease or locally advanced disease that's not amenable to resection. Probably only 20% of the patients will come to resection. And the difficulty is, of course, as you can see, that a lot of the symptoms described as being potentially associated with pancreatic cancer are not, they're not particular to pancreatic cancer. So general symptoms like weight loss, abdominal pain, nausea, vomiting, dyspepsia, even pruritus, and of course jaundice may well be obstructive jaundice, but again could still be related to other causes. The symptoms highlighted in blue, so new onset diabetes, lethargy, and back pain, are the three that have most commonly been found to be probably more particular to pancreatic cancer. And certainly new onset diabetes in older patients, if it's associated with abdominal pain or back pain, should really ring alarm bells in terms of getting some form of cross-sectional imaging, usually CT scan, just to see if there's any obvious changes in terms of pancreatic soft tissue mass. The underlined changes are changes that have also been noted to precede diagnosis by up to about 6 months. So that's change in bowel habit, lethargy, back pain, shoulder pain, and also interestingly dysphagia was not actually listed as one of the more common or alarming symptoms to be noted. So in terms of investigations, it probably depends a little bit on where you are with the patient, but presuming if you have a patient who's had imaging of sorts, which is suspicious for pancreatic cancer, what we'd ask for is the sort of basic things, so usually your general bloods, but also tumor markers. And tumor markers that we usually look at are CEA and a CA19-9. And some places would also add a CA125, and as a combination, you decrease the sensitivity, but you do increase the specificity in terms of trying to find diagnosis. We do need to remember, though, that a negative result shouldn't exclude the diagnosis of cancer. Some people simply won't be able to produce those antigens, and so you won't necessarily see a rise in those tumor markers. So if you do see a mass and you're concerned that it's cancerous, then it is appropriate to order tumor markers. However, tumor markers for screening are probably inappropriate in that, if they're negative, it doesn't exclude anything, and if they're marginally raised, it tends to cause more anxiety, particularly if we're not actually able to find anything on follow-up imaging. Most people have had a single phase CT scan, which will show possibly a lesion, but that doesn't really characterize it much more than that. So what we normally then organize or ask you to organize if we feel like there's going to be a potential delay in actually getting to a clinic is a CT pancreas. And it's essentially a CT of the abdomen and pelvis, but with a non-con arterial and venous face, so that we can actually look at the enhancement patterns and characteristics that will then give us an idea as to whether this is in fact something we should be concerned about and what the next steps would be. On that scan as well, we look at the vascular relationships. This, of course, is informative in terms of deciding whether or not cancer is resectable or not. and I'll go into that in a little bit more detail shortly, but also will potentially demonstrate metastatic disease if there is abdominal disease. MRI of the pancreas probably adds little in terms of pancreatic cancers per se. I think it's a very good investigation if we're looking at a stricture with an unknown cause, or perhaps pancreatic cysts such as IPMN, etc., if they're reported on the CT scan, but probably don't add too much if you're thinking along the lines of cancer. And certainly the sensitivity is pretty comparable, if not slightly reduced compared to CT for that particular cause. So just to sort of highlight a couple of things, and I hope that this cursor actually does show as I come across. But the main things you're looking for in the report, and are you looking to see if you have a hypoattenuating lesion described, and also they tend to be associated other symptoms, particularly for a head tumor, for example. We expect that because these are going to be at the head or the uncinate, there might be involvement of the ampulla. And so we see dilatation of the pancreatic duct and sometimes associated dilatation of the biliary duct. And that can occur even in the absence of jaundice. So that's some of the things that you might see described in the CT scan reports. And also, with an obstructed pancreatic duct from the tumor for some time, there might be distal pancreatic atrophy. And those sorts of things are what we're sort of looking for, the things that when we see them in the report, we find most concerning. So this is one such image, and that's just the cross-section of the same patient. And again, just sort of looking at that. And again, on this imaging is when we can sort of start to look at the vascular involvement. And we're now at a point where we would consider resection in some people even with vein involvement to a degree, providing they were fit well without any other disease, but probably not so much in terms of arterial disease. There are centers in the world that have performed resections with arterial involvement, but generally in terms of morbidity and like the actual long-term outcome, there appears to be very little to add to that. So this is probably a more sort of drastic picture of a locally advanced tumor, but they can actually be small tumors, but that just happen to involve vessels. But this is a larger tumor, and as you look at it, you can just see the pancreas with some dilatation coming across here. But what you'll notice, and what really makes it locally advanced apart from its size, is the fact that as you come along onto the major vessels that are away from the operative site, so sort of your SMA, these are all encased in tumor and nodal disease, which means that they would require resection of blood vessels, which we know you don't benefit from. And of course, we do need to be able to keep your SMA for your viability of your bowel. So again, that's usually something that would mean patients were not resectable. But a picture like that would obviously then change what we're thinking in terms of management and diagnosis. And lastly, of course, is the patient who presents with already metastatic disease. So what does happen sometimes is we do get referrals and then initiate investigations before a clinic appointment. And part of that is to be able to actually guide carefully where patients end up. Because of course, if they've got, for example, locally advanced disease and they're not necessarily coming up for an operation, we may actually organize them having biopsies prior to coming to a clinic appointment, because then we can refer them to an oncology appointment instead of a surgical appointment. I think most patients do find it somewhat disappointing when they turn up to a surgical appointment where clearly they're not planned for an operation. It's not something to have as a discussion, and they're not able to get as much information either about the next step in terms of their oncological treatments. And that's why it might feel like a delay, but it's actually part of the process to try and make it happen sooner. In terms of actually diagnosing pancreatic cancer, in terms of tissue biopsies, there's different approaches. So we use endoscopic ultrasound quite frequently now, at least in WA. This is different across different states. There are places where if you present with resectable disease, then the preference would be, as long as the imaging is all suggestive of and tumor markers are also effectively raised, it might continue on to a resection. It does have its advantages in that you obviously mitigate the risk of any complications of EUS. However, you do increase your rate of negative resection, which is important when we remember that these patients are having big resections like Whipple, and also distal pancreatectomy is not without its complications also. However, we'll go with EUS in the patient who's not jaundiced and clinically otherwise well, with an obvious mass related to their pancreas. This is generally done as a day procedure. There is a risk of complication, including pancreatitis. We don't see it very often, but we do have the occasional case of severe pancreatitis, which then delays further treatment, secondary to EUS and biopsy. For the jaundiced patient, we tend to try ERCP in the first instance, partly because then we can have therapy in terms of achieving biliary drainage, and at the same time taking brushings for cytology. It is, however, low yield in terms of diagnosis, and sometimes these patients will still go on to end up needing an endoscopic ultrasound to confirm diagnosis despite the initial ERCP. And there is a cohort of jaundiced patients who will have an EUS first, and these are the ones who look upfront resectable, are fit and well, and although jaundiced are not cholangitic, we would often, if possible, and the logistics allow, go on to an EUS with a planned resection within the next couple of weeks, so they actually stay jaundiced until resection, and therefore, again, you can try and avoid the risks of ERCP, which also can cause pancreatitis and can make dissection difficult at the time. Once we've made a diagnosis, we'll usually go on to organize a PET-CT, and this will change the management in about 10 to 15% of patients having found further disease in terms of distant metastases, and it may well also show local regional metastases. But again, that helps with counseling the patient in terms of what treatment they're likely to have following their surgery, although we usually will warn most of them that the likelihood is that if they're going to have a resection, they will be going on to adjuvant chemotherapy if they don't need it preoperatively. For those patients coming on to who look like they've got distant disease on CT scan or PET scan, we will sometimes go for a different biopsy. So for example, if you've got multiple large liver lesions which are easy to access, those can be biopsied without the need for sedation or general anesthesia, which is required for an EUS or an ERCP. And so in that setting, we might organize a radiologically guided biopsy of that instead. And certainly for those ones that are able to come to surgery, we go on to do further investigations, including staging laparoscopy, etc. And so this is so from diagnosis to actual intervention can take up to 4 weeks, if not more, particularly where it's not clear in terms of diagnosis. So the diagnosis is difficult, I think, from all ends. It's difficult from the initial findings from yourselves with patients presenting with what essentially fairly ubiquitous symptoms for just about everything else under the sun. Dyspepsia wouldn't necessarily lead you to thinking each patient with dyspepsia has pancreatic cancer. So it is often a delayed diagnosis, and many patients will present with advanced disease. Those that present with early disease are often incidentally found having been investigated for something else and have a CT scan that demonstrates that. In terms of who to refer on, we're certainly happy to hear about all referrals, but urgent referrals for new suspicious masses, and we will sometimes ask for some initial investigations. But also emergent referral is warranted if patients are unwell. So if they're cholangitic, if they've got pruritus, pancreatitis, or gastric canal obstruction, or something that requires emergency care, then they need to come in through an emergency department. The jaundiced patient who is not cholangitic and doesn't have pruritus and is comfortable waiting at home, we can certainly take an urgent referral and make sure to see them sooner rather than later and organize them in that fashion. But if there's ever uncertainty, we're more than happy to be contacted, excepting, of course, that it does require a multimodal approach. It's difficult to diagnose, and I think the multidisciplinary approach, especially if we can all talk to each other, makes a huge difference to their overall outcome.
Thank you, Mandy. We do have a question here for Chris. Chris, what are the current immunotherapy trials telling us with reference to the website emergingmed.com?
So unfortunately, there's not that much of a role for immunotherapy in pancreatic cancer at the moment. It is one of the tumours that's regarded as cold, so not responsive to immunotherapy. So there's some work going into looking at how we can make these cold tumours hot, I guess. Some patients who have pancreatic cancer might have a particular mutations in the cancer that make them more susceptible or more responsive to immunity. So patients who have Lynch syndrome, for example, they might have what they call microsatellite instability, which would kind of make us think that immunotherapy would work quite well. That's probably only 1 or 2% of patients, so not very many patients at all. So they're a very limited role for immunotherapy in pancreatic cancer at the moment. I think it's probably going to be one of the cancers where immunotherapy is not going to be a big player unless there's massive changes, certainly not current immunotherapy treatment at the moment. Unfortunately, outside of that very limited setting, there's certainly nothing available PBS-wise. So we do look for trials for those patients. I have one patient with Lynch syndrome, pancreatic cancer, etc., for a trial so she can access immunotherapy.
Okay, thank you. We don't have any other further questions, so unless Chris and Mandy, you'd like to make any other comments? We'll bring that to a close for this evening. Thank you so much, Chris and Mandy, for sharing your time and expertise with us tonight, and thank you to our audience for joining us. Please look out for your evaluation forms tomorrow. Thank you. Good night.